Hello everyone, my name is Ray and I'm a Chinese vet. I work for IVC Veterinary Hospital and my interest is in anesthesia. So today I just want to share some of my experience with you guys and let's see if there's anything new for you or if there's any new knowledge for me for patient assessment. These two pictures are from my hospital. The first one is our reception area, and the second one, of course, this is our surgical theater. And we can see the anesthetic machine and the monitor and the beer hugger, everything like that. Yeah, I wish I can see you guys someday, probably in China. If you guys visit China, please come to our hospital and we can learn from each other and have a good time. So let's talk about animal assessment before anesthesia. First thing we need to discuss is the ASA scale system. I know everyone using ASA scale system because it is just so useful. The reason why it has been widely used all over the world is because it gave you a level 1 to level 5, sometimes with a level E, which is emergency system. It just make everything easier for us and for clients to understand if the patient's anesthetic risk is high or not. We can see there are two pictures on the slide. One of them is the original ASA scale system and the other is slightly modified. For our hospital, we've been using the scale system with the emergency level. It makes things much easier for us, and also for nurses to understand the patient's risk level, because it gives you a precise description of the patient, how you scale the patient, and the disease, like the examples for different levels of the patient. For level 3, the patient may have controlled diabetes, and for level 4, the patient may have sepsis, organ failure, or heart failure. The other one, from the other picture, we can see instead of giving you a certain disease, it gives you a symptom. Sometimes it's a fever, like the level, still for level 3, the patient with severe systemic disease, it will give you a symptom like fever, dehydration, anemia. So I think this ASA scale system, it doesn't matter which modified version you are using, as long as it helps you and make it easier for your work, you just keep using it. The thing that I will talk about today is how we make a accurate ASA scale. Like, how do we get all those informations? We can say, okay, this patient is level 3 anesthetic risk. The ASA scale is level 3. Okay, what informations we need to get to support our idea? This is very important. How do we achieve pre-anesthetic assessment? In our hospital, we normally run things in this order. We first take information from the patient, which is signalment plus history. We run physical exams on our patient. We collect diagnostic data. Sometimes we run blood works. Sometimes we get blood results from other hospital. And the thing that most of us overlook is the procedure that we do to our patient. Some of them is MRI, is non-invasive, and some of them surgeries, especially orthopedic surgeries, emergency surgeries, sometimes those invasive surgeries can actually increase the risk level of the patient. So let's talk about the signalment. It includes species, breed, age, and body condition score of the patient. There are more information about signalment, and here are just 4 examples. Well, let's talk about the species and breed. Different species, especially dogs and cats, that's the most common species that we treat here in China in small animal hospital. I think, in a lot of places in the world, we have rabbits, lizard, and other exotic animals in hospital, but that's not normally what we see here. Just talk about feline patients and canine patients. They are quite different. Cats have narrower airway opening and can easily get a laryngeal spasm, and the dogs have wider and bigger airway opening, so they are mostly easier to intubate. And that's the reason why we normally have our nurses, the new gravidates, intubate dogs to build up confidence, but not really intubating a small cat, which can make things bad. And we can also talk about the mortality rate. The death rate during anesthesia for cats are much higher than for dogs. And talking about the breed, well, the worst breed I think I've ever seen is the British Philic. I'm not saying that breed of dogs are bad. I'm just saying because their anatomy, structures make they more difficult to intubate, and they're much easier to guide hypoxemia. And some of the British Philic dogs, like pugs, they have 6 sinuses syndrome. The same thing can happen on White Highline, a white terrier. And for like Doberman, they tend to have heart problems. And the same thing may happen on boxers. So if this breed of dogs come into clinic, we need to know what may happen to them, what kind of conditions they may have can cause problem during anesthesia. So I got a picture from textbook list. Some of the breeds may have higher risk during anesthesia. We can see British Philics patients, they may have airway obstructions. The Huns, well, I've seen Huns are so sensitive to espromazine that they've been sedated for a whole day. So what I want to talk about here is for pugs. I don't think pugs has been listed here. I've seen 3 cases of all of them are pugs in our hospital. And so for our first patient, I didn't run ECG before. I sedated him. He had a so after I sedated him, I can see the tongue get blue, and the peripheral circulation just decreased dramatically. And we put him on oxygen. We get all the ECGs, the blood pressure, everything was connected. And then I read on ECG. Well, that pug obviously has 6 sinus syndrome, which is bad. We can see actually it get to atrial arrest. the heart rate was about 20, and atropine, it just doesn't work. It just rang the bell to me, like this kind of breed may have, this kind of problem. And the rest of two pugs, luckily, we ran ECG first and find out, well, they, both of them have sick sinus syndrome too. That's just the story happened to my clinic that I want to share with you guys. Just be careful, because this picture doesn't list everything. We still need to find out what may happen on different type of breed during our clinical work. Here, something else that I want to say is the Persian cats. The polycystic kidneys, it is, I don't know if it is, the same situation in everywhere else in the world, but here in China, in our hospital, it probably 1 of 10 cats we see have polycystic kidneys for Persian cats. This is a really, really high rate. And without doing ultrasound, some of them, if you run pre-anaesthetic blood work, biochemistry, there won't have any changes in urine, creatine, all these kind of parameters. But if you run ultrasound, you can see there are, cysts on their kidneys. And if you run anesthesia on this patient, they will have pretty high risk of acute renal damage after anesthesia if the blood pressure wasn't well controlled during anesthesia. Age of the patient can affect anesthesia risks dramatically sometimes. Very young patient and very old patient can make the anesthetic risk much higher. So, talk about young patient. The youngest patient we've ever seen was 20 days old. I think the oldest patient was 21-year-old cat. So for both time, when we try to anesthetize those two patients, our team was very nervous because, for their life stage, their life is really, really fragile. Even without anesthesia, without proper care, they may just die, even when you're doing nothing. So this is very, very important. I know it's an easy thing. It is a very easy thing for us to overlook, because sometimes our consult vet get a client, and he will just transfer the case to the anesthesia department, saying, okay, we need anesthesia, and this patient needs an MRI. When we collect all the data, there are two things, the most common thing that may miss. One of the age of the patient, and the second is the body weight of the patient. It's very, very funny. We all think those two are very important, but to be honest, sometimes we remember to run the echo on our patient, to take x-ray, blood work, everything. But sometimes we just fail to get the age of the patient or the body weight of the patient to our anesthetist. For younger patients, what we know about young patients? They have higher body water content. They have immature renal and hepatic metabolism and excretion pathways. Well, they have increased blood-brain barrier permeability. their cardiovascular function isn't mature enough. Their heart is stiff. They have poor response to things like adrenaline, noradrenaline. The cardio output mostly depends on the heart rate. The respiratory system for the younger patients is, well, I'm not going to say they're purely mature. Their respiratory rate are much higher than older patients because they have high metabolism rate. They need more oxygens. They have lower fat and glycogen storage, which means they are easier to have hypoglycemia. We need to give young patients more glucose and have shorter fasting life. So most of the patients, for adult patients, we normally ask the owner, our clients, to fast them for 6 to 8 hours before general anesthesia. But for young patients, we normally will ask the owners to fast them for 4 hours. So according to the information on this slide, the things we know about young patients is we need to use lower dosage of pre-anaesthetic medications and induction drugs for our young patients because of the high blood-brain barrier permeability. Most of the young patient doesn't react to adrenaline, noradrenaline, dopamine, dobutamine well enough. They will react to those drugs. They just won't react as good as adult patients. In order to build up their cardio output during anesthesia, the better way for us is to use atropine or glycopyrrolate to increase the heart rate because their cardio output is heart rate dependent. Higher body water content means we may need to give higher fluid rate for our young patient during anesthesia than older patient because they have higher body water content. Certain type of drugs should not be used on young patients such as gentamicin because the young patient doesn't have mature renal function. So now we know more about the drug selections and the time for fasting, what type of drugs that we it's better to use in order to increase the cardio output for young patients, just according to information on this slide. So from this slide, we can know something about our older patient. In most of the older patients, they have progressive neuroatrophy. The brain-blood barrier permeability is actually increasing in older patients too. So which means we also need to give lower dose of pre-anesthetic medication and induction drugs and probably reduce isoflurane percentage during general anesthesia. Some of our older patients cannot see or hear, and their thermoregulatory reflex is reduced. The cardio output of the older patients are lower. They may have cardiac degenerative changes, and their chest wall compliance just reduced. We normally put our older patient on ventilator during surgery because of this. The GFR and liver function is reduced too. So for a lot of renal toxicity drugs and liver metabolized drugs, we need to, when we use them, we need to be cautious. Here what I want to say is For older patients, there are two different types. One of them, they have very low body fat, and for those older patients, they are actually quite skinny. Sometimes we may think if the patient's having hyperthyroidism or something like that. Sometimes they just thin. For this patient, like younger patient, it's better for us to reduce the fasting time. 4 hour fasting time should be enough. And there are also another type of older patient, which means they're super fat. They actually, quite overweight. So for this patient, that's another story because their body weight doesn't mean their real body weight. So when we gave them medications, we may give them too much. Sometimes when we reduce the dosage of pre-medication drugs, it doesn't work well. But when you use just enough, it's really difficult to use just enough dose of drugs. Sometimes when we give them a little bit more, and they tend to, wake much slower than skinny patients. So yeah, like what I said, I probably talked a little bit about body condition score in last several slides. It is very, very important for us, like everything, we talked about just before. For patients are too skinny, we need to think about their blood glucose level, because they're just too easy to be hypoglycemia. We also need to worry about the fat patient, because sometimes, especially when they're doing abdominal surgeries, when they having this dorsal position, when they have very high abdominal pressure, all the pressure, all the organs just push on the esophagus and make the chest pressures getting higher, and they'll not be able to breathe enough air because of this during anesthesia. So that's the reason why for a lot of overweight patients that we tend to put them on ventilator. Thiopentone is a type of induction drugs that we barely use these days. But the funny thing is, for when we use it before, probably 2 decades ago, the patient having thiopentone, when the fat patient get thiopentone, they need a lot of thiopentone to be anesthetized, and but after general anesthesia, it took them quite a long time to wake up, just because some types of drugs, just like thiopentone, they can diffuse in the fat tissue and slowly released later on. And another thing about skinny patient would be, like I said before, the smaller they are, their skin area and body weight ratio would be higher, which means they will lose a lot of heat during general anesthesia. They tend to get hypothermia very easily. That's another thing we need to think about, and we need to give them a bear hugger, monitor their temperature, body temperature closely. For patient, for overweight patients, that's not. I'm not gonna say there's no problem for their body temperature, but it's just gonna be safer for them because they tend to lose less weight, as their body fat can keep those heat inside of their bodies. Medical history is very important for anesthesia patients. So some of the patient may undergo anesthesia before, and some of the patient may have surgeries before. So when patients undergo anesthesia, they may react to different types of drugs differently. Like we normally have our anesthetic record sheet. Any complications about anesthesia will be written on that sheet. So we can see hypotension, hypothermia, hypertension, bradycardia, all these kind of complications in that sheet. And that sheet will be used as former medical history for next time when patient come to the hospital. This is really important. Like I can give you guys an example. We got a case before. It's a White Highland White Terrier. The dog came to our hospital for a dental cleaning procedure, and we just pre-med the dog and gave him dexmedetomidine and butorphanol. Everything goes very smooth. And then we start to induce the dog. We give him propofol. And while we doing the induction, we realize the dog's face is just, swelled. And the mucous membrane get red. The temperature get higher, and the respiratory rate is getting higher. We found out, okay, the dog was having allergic reaction. Then we stopped giving propofol to the dog and give him antihistamine and wake him up. The most important thing later on was written the medical record on the sheet. Propofol allergic. This is really important. Think about if the patient come to the clinic next time. So if we didn't make any record, the dog come here next time and we gave propofol again, what about the allergic reaction happen again? Maybe it's just another simple allergic reaction. Maybe it's fatal. Who knows? So that's part of the reason why we need to check the medical history. For a lot of patients may have, hyperthyroidism. Some of them may have Cushing's. Some of them may have Addison syndrome. For all those patients, they may be on medication. They may not. It's really important for us to get a full medical history of them before we actually put drug into their IV catheter. Another very important thing is the surgical procedure. Well, I think it may be more important for the surgeons, but actually it's part of our job too. I give you guys another example, which is funny, but I feel sorry for our surgeon. One of the lady, our clients, found a cat on the street. She thought it was a street cat. She took her home, vaccinated her, and 6 months later, she thought the cat was on heat. So she took her to our clinic, and everything goes well. All the blood work goes well, physical examination goes well, and we all thought, okay, this is the case. We may spay her. We put her under general anesthesia, and our surgeon just opened her up and tried to find the uterus. It took him probably 15 minutes to realize there's no uterus at all. I'm not gonna say this thing will never happen in a good clinic. It may happen because that cat was lack of medical history, and that's part of the reason why this kind of situation happened. We can imagine the cat, instead of having her abdominal wall cut open under general anesthesia and digged by our surgeon, there's nothing changed because she's already been spayed. That is why we think it is very important to get a full medical history of our patient, including the medication history, the history about the disease, and the history about the procedures such as surgeries has been done to the patient. Medical history is very important. I know this is how many times I say it, important. We list several types of drugs here, and that's what we normally used before or during or after general anesthesia. Let's discuss about all these type of drugs. So first we want to talk about is antibiotics. Well, we use antibiotics during or before surgeries. For orthopedic surgeries in our hospital, we tend to use sulfasalazine 30 minutes before surgery. For other type of antibiotics such as gentamicin, it may cause severe renal toxicity. So for young patients and for older patients, we tend not to use it. But what about the patient that under gentamicin? When they are using gentamicin, what we need to worry or what we need to focus or what we need to pay attention on during general anesthesia? If we know gentamicin can cause renal toxicity, can cause renal damage, we may pay more attention on blood pressure control during general anesthesia just to support the GFR. Non-steroid and steroids are commonly used in our practice. But when you use them together, it will cause GI tract ulceration. Sometimes, for patients with arthritis, non-steroids can be used long-termly. But it can also cause renal function. It can also decrease the renal function. When renal function was decreased, it may cause more problem. And this is something that we need to think about before we perform general anesthesia on these patients. We get a lot of elder patients in our hospital for general anesthesia. Sadly, when patients get older, they tend to have more problems that needs to be checked or needs to be, need surgery to be done on them. So general anesthesia are required for these patients. We put those patients on different checks, on echo. Sometimes they have heart issues, and they may be prescribed ACE inhibitors such as enalapril, calcium sensitizers, pimobendin, cardiac glycosides such as digoxin, and beta blockers, ASMOR. So what I'm talking about here is we need to pay more attention on beta blockers. I've been asked if I will choose to stop giving beta blockers to our patients before general anesthesia. Some people think beta blockers will cause reduce the effectivity of dopamine or dobutamine during general anesthesia or during the daily use. I've never seen this kind of cases happen to me, to my case. I would say if I were the anesthetist, I would still give ASMOR a day before general anesthesia. And because most of the times ASMOR will cause more advantages than disadvantages. So anticonvulsant drugs such as phenobarbital. So if the patient is suffering from seizure, which we have a lot of cases these days come to our clinic to have MRI. A lot of them they have seizures. So if the patient was on phenobarbital, we need to reduce the drugs that we gave to our patients. Phenobarbital itself can cause sedation. And think about this. When the patient's having seizure, the worst thing is to excite the central nervous system. So ketamine, Zolotil, or Tilazol should not be used in this patient during this period of time. A lot of people will say benzodiazepine is a good choice. I'm not very sure about this kind of situation because, like diazepam and midazolam, diazepam is mostly used in acute seizure control. The thing is, if you use diazepam frequently, the effect that caused by diazepam will not, the effectiveness of diazepam will not be as good as when you first use it. Antidepressant such as Signalment, if you use it with tramadol, it will cause severe serotonin syndrome. We had 2 cases before in our hospital. Both of them are cats, and both of them, after we gave tramadol, they all have serotonin syndrome, hypersalivation. They just jump in the cage. It's a very scary scene, and our nurses don't really know what to do, so we just gave fluid therapy. Both our patients' owners, they use antidepressant, and we ask them after this kind of thing happen, and they say they do have antidepressant at home, but they guaranteed that the cat will not have the access to those drugs. This is the thing that we talk about here, is we still need to think about all those possibilities. Even when the owner said, okay, they will never get to the drug. So now we talk about physical examination. What we see about physical examination here is what we can see directly on our patient. So first, we can get a general idea of the body condition score of the patient, 1 to 9. So give them a score. And about the hydration status, and we can just simply check the mucous membrane color, the CRT, the skin tension, and if there is a sunken eye or not, the moisture of the mucous membrane. All these kind of parameters can indicate hydration status of the patient. The cardiovascular parameters, all the heart rate, pulse rate, blood pressure, CRT, mucous membrane, ECG, and all those things can support our idea, can give us a general idea of the patient's cardiovascular function. Respiratory system, what we can see through is the respiratory rate, the mucous membrane color, if it is pink, if it is red, if it is cyanosis, and the GI system function, if the patient's vomiting, if the patient's having diarrhea. So it also has connection with the hydration status of the patient too. So if the patient's having PUPD, what about the skin condition of the patient? And what about the central nervous system? Like what we said before, if the patient was too thin, we need to worry about hypoglycemia, worry about the body temperature of the patient. If we're giving too much drug to our patient, if the patient can, if the patient can wake up smoothly, if the patient is fat, we need to think about, if we're giving the patient enough drug, and if the patient can wake up, soon. Hydration status, if we need to give the patient fluid therapy before general anesthesia, right? Cardiovascular system, we want to see if the patient is having a good cardio output. If we put the patient under general anesthesia, is the cardio output is big enough or adequate enough to support the whole body condition or the organ function. The respiratory thing, some of the patients may have lung fibrosis, right? So when they under a general condition without general anesthesia, they may have a higher respiratory rate, but with a blue mucous membrane color, right? So this patient during general anesthesia, we may think what we need is a ventilator, or we need 100% oxygen therapy before general anesthesia. PUPD sometimes just indicates hyperthyroidism, Cushing's, Addison's, diabetes, and all this kind of a lot of drugs. This is part of our diagnostic, indicator. When we see a PUPD patients, we never just put the patient under general anesthesia. It's always better for us to check if the patient is having something that we don't know, have any problem that we are not sure. Sometimes people think, okay, skin infection, skin disease. What's the problem with skin disease? What will affect anesthesia? Like, I will give you just a simple example. If the skin is severely infected and you want to put an IV catheter, right? If you're not scrubbing the skin clean enough, the IV catheter will transport the bacteria into the blood vessel. And what about the epidural? I mean, if you perform an epidural to the patient with a severe skin disease, it may just higher the risk of a infections of the spinal cord. For the central nervous system is very important too, because a lot of patients that we took in, they may have damage on the brainstem, which means their cardiovascular center, their respiratory center may be damaged. This is really something that we need to think about before we actually put the patient on the table. Now we can talk about the hydration status. Here on the slide, there's a picture from Basava textbook of anesthesia. We can see there are clinical assessment findings that we can see to support our ideas about different levels of dehydration. This is very subjective. Different people may have different ideas. What I want to say here is, if you find out the patient is above 8% dehydrated, it's going to be a better idea to stabilize the patient first instead of anesthetizing the patient. So when patient's dehydration status is higher than 12%, it means the patient's at least suffering from hypovolemic shock, and a lot of patients may die because of dehydration, higher than 12%. It is very important to run blood work before general anesthesia. But some of the research has been shown that only a small percentage of cases was delayed because of the blood work's result. Shows the unexpected body condition of the patient or the organ functioning of the patient. We can see this is a research from Leipzig University. They analyzed over 1,500 cases of anesthesia in 2008. There's only 0.8% of the cases need to delay anesthesia, and about 1.5% of the cases needed extra treatment after blood test. So which means the majority of the case, our anesthetist or our vet can get a rough, accurate idea about the patient's level, and the patient may go through general anesthesia safely. Well, there are also research that was done in UK from 2002 to 2004, there are over 200,000 cases of anesthesia was analyzed. The result shows that the patients was leveled between ASA 3 to ASA 5 level. Running blood tests can significantly reduce the risk of anesthesia caused death. I think the reason why this running blood test itself won't change anything. I think it's just because we read the test result just shows there may be unexpected damage of certain organs, or the animal's body condition may worse than what we expected. So we try to stabilize the patient before we run general anesthesia on them. This step reduces the risk of anesthesia caused of death. And that's the importance of blood work. Another thing is, running blood work can also help us explain the body condition of the patient to the clients. Without running the blood work, we only talk to the clients like the patient's very risk, at very high risk of death during anesthesia. There's no parameters to support our idea. Sometimes the client just won't understand and won't believe. The work we normally do is CBC and biochemistry. Sometimes we will add on blood gas for critical patients and for young and older patients. Blood coagulation, sometimes we run it for certain species and for patients that gonna go through major surgeries. Blood smear, we will make blood smears for every CBC patients, and inogram. That's for like PUPD patients, for fat patients or super skinny patients. It can help us rule out Cushing, Addison, hyperthyroidism, and diabetes. We only run blood tests according to our clinical findings, and mostly for our ASA level 1 and ASA level 2 patients, we only run CBC and pre-anesthesia biochem panel. That include uric creatinine, ALT, AST, blood glucose, and total protein. And for patients between ASA 3 to ASA 5, or patients that are older than 6-year-old and all younger than 5 months age, we're going to run the CBC and full biochemistry panel. There are also diagnostic imagings that we can run before general anesthesia. It also depends on our clinical findings. If we find our patients having seizure, it's better for us to run the MRI before we actually do any other surgical procedures to our patients. However, running an MRI or CT with contrast requires general anesthesia. So we need to balance the risk and the test. For a lot of patients with respiratory depressed and extended abdominal wall, we can run the X-ray, ultrasound, or if we hear a heart murmur and it appears to be funny on the ECG, we can also give the patient an echo to see what is going on with the patient's heart. Again, this test is totally depends on our clinical findings, and all these results came out can support our idea or give us a general idea about the problem that we found, how it will affect our anesthesia. Here are some pictures of the X-ray machines, MRI, ultrasound, and CT machines in our hospital. It will never be a bad idea to stabilize the patient first before general anesthesia, especially when patients are suffering from severe electrolyte imbalance, hypoglycemia, shock, moderate to severe pneumothorax, moderate to severe hemothorax, pyothorax, pulmonary edema, cardiac tamponade, severe arrhythmia. Under all these kind of circumstances, stabilizing the patient first is the best choice. Here is a picture about body fluid distribution rate and the starting equation. It illustrates the body fluid movement. Fluid therapy can help hypovolemic shock and electrolyte imbalance. For hypovolemic shock, we can give isotonic crystalloid to our patient. For canine patients, we normally give 90 ml per kilo as a bolus, and for feline patients, we normally give 50 ml per kilo as a bolus. But in our practice, we tend to give half of that dose at once and to see how it works. Normally, it will support the patient's blood pressure for probably 20 to 30 minutes. If there's no effect, or the shock get back again within 15 minutes, then we're going to use colloid, 10 to 20 ml per kilo. We give it within 10 minutes. For severe anemia patient, it's never be a bad idea to stabilize them and give them blood transfusion before general anesthesia. The canine patients receive 2 ml per kilo whole blood. The PCV will increase about 1%. And the first 20 minutes, the blood transfusion rate should not be above 0.25 to 1 ml per kilo per hour, just in case of blood transfusion reaction. The highest blood transfusion rate should better below 4 ml per kilo per hour. Here's an equation that we can use to calculate the total blood volume that we need to give to the patient. For our feline patient, it may not be able to get enough donated blood from another cat. We normally give 1 to 3 ml for our first minutes to see if there is any blood transfusion reaction. The highest fluid rate or the blood transfusion rate could be 5 to 10 ml per kilo per hour. However, for a lot of feline patients, we still need to give the blood as soon and as fast as possible. If the patient's having a heart problem, we better give the fluid rate or the blood transfusion rate below 4 ml per kilo per hour. Here is the equation for feline patients' blood volume that they need for blood transfusion. Here is the references for the slide, and thank you guys for listening. Thanks. See ya.